Hello everyone, and thank you for joining us today. Welcome to today's Lunch and Learn seminar series on the STOP program, an example of evidence-informed practice in smoking cessation. Today's presenters are Dr. Laurie Zawertailo and Erin Cameron. If you are interested in obtaining a letter of completion for today's session, you must have already completed the registration form and pre-learning assessment. You must sign in to the live webinar using your first and last name, and you must complete the post-learning assessment too following the webinar. These webinars are being live tweeted on Twitter. Please follow CAMH Nicotine Dependence Services on Twitter at PSQuitSmoking. To follow the live tweeting or to post your questions or comments, please use the following hashtag #TeachWebinar. These are today's presenters. Dr. Zawertailo is a clinical pharmacologist interested in treatment interventions for smoking cessation, especially in comorbid populations. She is also the scientist for the STOP program study and a province-wide smoking cessation intervention that has enrolled more than 100,000 smokers in Ontario. She's an assistant professor at the Department of Pharmacology and Toxicology, Faculty of Medicine at the University of Toronto, and is a member of the School of Graduate Studies at the University of Toronto. She has published more than 25 peer-reviewed articles, including those in high-impact journals, including Archives of General Psychiatry, Clinical Pharmacology and Therapeutics, Neuropsychopharmacology and Addiction. Dr. Zawertailo has received 17 research grants and contracts totaling more than $5 million over the past 10 years, including current active grant funding totaling $750,000 as PI. Erin has been working as a research coordinator with the STOP program since 2012. Her main focus is working with addictions agencies across Ontario to help integrate smoking cessation treatment into their practice. She completed her Master of Public Health degree at Queen's University, where she was involved with the Leave the Pack Behind, a comprehensive age-tailored tobacco control initiative for young adults on post-secondary campuses. These are the disclosures for today. The TEACH curriculum and slides were developed and compiled with funding from the Government of Ontario, specifically Ministry of Health and Long-Term Care. Content of the slides are primarily based on evidence-based guidelines, including the following 3 sources. The development and delivery of the TEACH curriculum is not influenced or funded in any part by the tobacco industry. TEACH has not received funding from the tobacco industry. The development of the TEACH curriculum has not been influenced by pharmaceutical industry. Information presented on pharmacotherapy refers to generic products only, and recommendations are based on existing research, including the Canadapt and US guidelines. These materials, as well as the verbal presentations and any discussions, set out only general principles and approaches to assessment and treatment pertaining to tobacco cessation interventions, but do not constitute clinical or other advice as to any particular situations, and do not replace the need for individualized clinical assessment and treatment plans by healthcare professionals. Okay, now I'm going to hand it over to our 2 presenters, and thank you for signing in today.
Hello, everybody. I'm Laurie Zawertailo. I'll be doing the first little bit of the presentation, and then Erin will take over in a bit. So the learning objectives for today is to learn a little bit about the history of STOP and the different models that we have done and are currently doing, and about a little bit about our successes and challenges. And then we're going to go through the knowledge to action cycle for evidence-informed practice, and so that you can understand the basics of this paradigm that we use to improve on STOP. And then a little bit about how you can integrate evidence-informed smoking cessation program into your own clinical practice. So what is the STOP program? STOP stands for Smoking Treatment for Ontario Patients. It is an evidence-based program for examining the effectiveness of different methods of providing cost-free smoking cessation treatment, so medication plus counseling to Ontario smokers. And our overall very lofty, ambitious goal is to decrease the smoking prevalence in Ontario. So in order to decrease the smoking prevalence in Ontario, we have kind of two approaches. One is to increase access to cost-free treatment for Ontario smokers, and the other is to build practitioner and system capacity for delivering smoking cessation treatment to patients and clients. And we feel that these two approaches will eventually decrease the prevalence of smoking in Ontario. And so, again, we think that we have, in a lot of ways, revolutionized how smoking cessation treatment is delivered through the STOP program. So STOP has been around since 2005. In 2005, the Ministry of Health came to us with one-time funding for nicotine replacement therapy, and they left it up to us to figure out how we would use the nicotine replacement therapy with the one kind of goal of reaching as many smokers in Ontario and across the province as possible. So the first thing we did was we partnered with tertiary care centres, so with CAMH, with the Ontario Heart Institute, and with Thunder Bay Regional Cancer Centre, all of whom have very specific nicotine dependence, tobacco dependence clinics and programs, and we distributed NRT through those avenues. But we realized that this was not reaching a lot of areas of the province and a lot of smokers that do not come to a specific smoking cessation clinic for treatment. So in January 2006, we conducted a mass distribution of nicotine replacement therapy by getting people to call into a toll-free 1-800 number and to be assessed and with brief counseling over the phone. And then if they were eligible, interested, they would receive nicotine replacement therapy in the mail. So over 13,000 Ontarian smokers registered for that program. And it was extremely popular. Within the first 36 hours of opening the phone line, we had almost half of our samples. So yeah, almost 7,000 people. So due to the success and popularity of these pilot programs, the projects, the STOP program was born, and our funding has continued uninterrupted through the Smoke Free Ontario strategy since 2005. So this slide is basically just showing the different iterations of STOP throughout the years, and then what we're currently doing. So let's see if I can find the arrow. There we go. So as I said, we started out in tertiary care centers. We did the mass distribution in 2006, and then we did subsequent ones in 2007 and 2009. We also moved into public health units, and we were in 13, I believe, public health units throughout 2006 to 2008, where the program was run through public health unit staff. And then we did a short program through community pharmacies, where smokers registered online and then went to their nearest participating pharmacy for cessation counseling and nicotine replacement therapy. Then we engaged with community health centers, and I'm going to skip over Stop on the Road because that's a special thing. And then we did another sort of mass distribution where the enrollment was internet-based, web-based, rather than a 1-800 number. We've been in family health teams and in private physician primary care practice in various iterations since 2009. But what we're currently doing, and this is these last 2, 4, 6, 7 iterations of STOP below at the bottom here. So we are in family health teams, I believe 130 some out of 180 some family health teams across Ontario. We're in 50 odd community health centers. We're in over 30 addiction agencies. And we also collaborated with public health units and the ministry to do the Workplace Smoking Cessation Project earlier this year. We are also in some Aboriginal Health Access Centres, 4 I believe, and we've just started engaging nurse practitioner-led clinics. And another ministry initiative, the hospital-based smoking cessation project, is something that we have been involved in since the beginning. So the one thing I do want to go back to is Stop on the Road. So Stop on the Road, as you can see, is the one thing that has continued almost since the beginning of Stop. And this is a very popular program whereby we take Stop on the road and we go to communities throughout the province, and we deliver a 1-hour psychoeducation workshop in partnership with public health units, and then we give out kits of nicotine replacement therapy. So this has been a very popular program where we register 5,000 plus smokers every single year. And recently, it's not us that go to communities. The public health unit staff conduct their own workshops and are able to do them whenever they want throughout the year, with, I guess, some limitations. So this is just a slide showing all of our clinic-based Stop models and how we've managed, even within primary care clinics and tertiary care clinics with one-on-one counseling, how we've managed to reach almost 60,000 smokers in Ontario through these different programs. And you know, that's a testament mostly to the interest in practitioners in delivering smoking cessation treatment through Stop. We didn't do anything. This is the hard work, seeing patients and counseling them to quit smoking. And then, as I said, we had our web-based and phone enrollment mass distributions, and through those, over the years, we've reached almost 47,000 smokers across Ontario. And then for Stop on the Road, another 20,000 participants. And these are all the places that we have been for Stop on the Road. So covering as much of the province as we possibly could. So since 2005, we have enrolled, I think we're at 130,000 plus now. And as I said, we have collaborated with hundreds of local practitioners. And I think that we've increased the capacity throughout the province to deliver smoking cessation treatment. So I think Erin's going to take over now and talk about kind of Stop as it currently is. Thanks very much.
Hi everyone, I'm Erin, and I'm one of the research coordinators with the STOP program. So I just wanted to basically take a step back and talk about how did we get here. So Laurie has talked about the reach that we have achieved in the province of Ontario, but what was the sort of background work that went into designing and implementing this kind of far-reaching program? So what we're really talking about here and over the next few slides is knowledge translation. So how do we design an evidence-informed program, and how do we put that evidence into practice? Because we know that where evidence is implemented, improvements in both costs and outcomes are seen. So what I'm going to be talking about over the next few slides is the knowledge to action cycle. This is a framework that was developed by the Canadian Institute for Health Research. And it's basically a way to guide putting evidence into practice on a larger scale. So we're going to go through the cycle, and each step along the way, we're going to talk about how STOP used this framework to engage with health practitioners across the province. So the starting point of the knowledge to action cycle, you can see at the bottom there, is to identify the problem. And so that was done for us by the Ministry of Health, where they wanted to reduce the prevalence of smoking in Ontario. And so the first step, once you've identified the problem, is to identify, review, and select the knowledge. And so the way that we do this is using what they call the knowledge funnel. And that's that triangle in the middle of the screen. And essentially what this is reviewing the evidence. So figuring out what evidence is out there to address the problem that you have identified. So how did we do this? So in order to review the evidence, luckily others had already done this. So there is a clinical practice guideline that is a US Public Health Service report that was put together by a panel of scientists and clinicians where they reviewed thousands of articles and data publications of the primary evidence for smoking cessation. And they put together this clinical practice guideline for treating tobacco use and dependence. So this is an evidence-based guideline that provides specific recommendations regarding brief and intensive tobacco cessation interventions, as well as system-level changes designed to promote the assessment and treatment of tobacco use. And so this, in combination with the CanAdapt guideline, which is a Canadian adaptation that was developed at CAMH, is really what formed the backbone of the STOP program. So let's take a look at what the evidence recommends. So the first thing that is in the guideline is called brief intervention. This is based on the 5 A's, which most of you have heard about. This is the 5 major steps in providing a brief intervention in a healthcare setting. And this is something that can be done in any healthcare setting. They define a brief intervention as 3 minutes, and they show that interventions as brief as 3 minutes can increase cessation rates significantly. So even if your practice setting is not able to participate in the STOP program, every healthcare setting can do the 5 A's. So basically what it is asking every client that you see if they're a smoker, advising if they are a smoker that they should quit completely. You then assess their willingness to quit. And if they're not willing to quit, they outline some strategies for motivational interviewing, which we won't go into in this presentation because there are full webinars just on that. But if they are willing to quit, you then move on to assist them in quitting by recommending pharmacotherapy or counseling options. And then you arrange for follow-up, and that can either be you following up with them, or they've even shown that telephone counseling services are also effective. And so referring them to a service such as the Smokers Helpline can also help increase cessation rates. So what the STOP program really wanted to do was focus on the assess and assist part of the 5 A's. So really focusing on offering that counseling support and the assistance through providing the nicotine replacement therapy. So just bringing this back to the knowledge to action cycle. So we've reviewed the evidence. The next step is to adapt this evidence to the local context. And so our local context in this case is the different healthcare settings. So we have both public health units, or whether you're working with a primary care setting like a family health team, how do we make sure that the evidence is adapted for them to use it in their setting? And so what we wanted to build on the 5 A's, so this is the next step in what the evidence recommends, is called an intensive clinical intervention. And bear in mind that intensive, they recommend, just means 10 minutes or longer. So it's still not a very long or intervention. They've shown that these intensive clinical interventions are more effective than the brief treatment, so just the 5 A's. And so this is what STOP really wanted to offer. So these more comprehensive treatment, which is multiple visits, so hopefully 4 or more, and longer periods of time per visit. And what the guideline says is that these intensive interventions can be provided by any suitably trained health provider and is appropriate for any tobacco user who's willing to participate. So that's really interesting because it doesn't have to be a physician or a nurse who's offering the intervention. So we could really use the rest of the healthcare providers that are out there in the system as long as they get that training in smoking cessation. And it's also not limited to any one practice setting. So, they don't say it just works with primary care. It's really for any tobacco user who would be willing to participate in this clinical intervention. So what are the components of an intensive clinical intervention? So the first component, as I mentioned, is clinician training. The second component is offering ongoing counseling support, and they show that individual and group counseling are both effective. And the third component is to offer that first-line pharmacotherapy options. And first-line options include nicotine replacement therapy, varenicline or Champix, and bupropion or Zyban. So the STOP program really wanted to capitalize on these components. The prescription medications we don't currently offer just because that limits the healthcare providers that could offer those because they're prescription only. However, NRT is over the counter, so it could really be offered by more practitioners. Okay, so that is how we adapted the evidence to fit into the local context. The next step in the knowledge to action cycle is assessing barriers to knowledge use. So how do we know if there are any barriers or challenges in place before we go into these settings to try and implement this program? So the way that the STOP program assesses barriers is by a capacity assessment survey. So this is the first step for every site that wants to come on board with implementing the STOP program, is they complete a capacity assessment survey. And this is just a brief survey that lets us know that they're interested and ask some questions about their current capacity to implement the program. So we're really in this survey trying to identify if there are barriers to implementation, any knowledge gaps, and especially training needs. So if they don't have any practitioners that are currently trained in smoking cessation, then we would know that from this survey and move on to offer them the training that they need. So after the capacity assessment survey has been submitted, the next step as we move through the knowledge to action cycle is to select, tailor, and implement the intervention in the specific setting. So let's take a look at how we select, tailor, and implement interventions. So there's a few steps that we go through with each site in order to increase the capacity within that organization. So we really try to make this a collaborative process so that we can develop a sustainable smoking cessation program for that practice. So the steps that we go through, as I mentioned, is staff training. And we do this in partnership with the TEACH project at CAMH, which leads a few different training options. They have their in-person and online comprehensive core course in smoking cessation. And they've also designed an online fundamentals of tobacco interventions course. This was designed specifically for STOP practitioners and is sort of a crash course or condensed version of the TEACH course. We then go through with each organization an initial discussion. This is where we discuss we talk about their overall implementation plan, get a sense of what their practice is already doing, and how they see the STOP program best fitting into what they're already doing. And this is where they would choose, if they want to offer group counseling, individual counseling, or whatever would fit in best with their setting. We then go through with every single implementer a operations training. This is where we go over the specifics of the program protocol. So how do they actually implement the STOP program when they see a client? There's forms to fill out, the different products that we have available, etc. And then finally, the last step is we actually provide that nicotine replacement therapy and the resources that they'll need to run the program. And one thing that I think is interesting to highlight here is that we do all of this remotely. So it's all done online. All of our trainings are online. Our discussions are over the phone, and we use mail services to send out all of our resources. So that's pretty incredible. It's allowed us to have our home base in Toronto, but reach out to all corners of the province
without having to actually do any on-site visits. Okay, so we're going to go through some of the resources that the STOP program provides. The first is our client assessment form. So every client that enrolls into the program has to fill out some sort of registration and or baseline questionnaire. And not only does this provide the STOP research team with data that we can analyze, but it also touches on a lot of points that are important for the clinician doing counseling with their client. So we talk about demographics. There's questions on their tobacco use history, their motivation to quit smoking, other substance use, other medical conditions, and medications that they might be on. So all of this can be important for the practitioner to use in their counseling attempt. We then, at every visit, we fill in a visit form with clients. And so what this does is that it captures a snapshot of their current smoking status so that we can not only evaluate outcomes, but we can also track their progress over time. So maybe they have cut down on their cigarettes or they're delaying the time to their first cigarette, etc. We then have a few implementation options that I'll just go over briefly. So in our family health teams, community health centers, addiction agencies, and nurse practitioner-led clinics. Currently, this is our most intensive program option. The site can choose either individual or group counseling, so we're fairly flexible in terms of how that will fit into their practice. The clinician can provide between 1 to 4 weeks of NRT per visit, and that can include combination therapy. So you can see the products that we offer at the bottom there are the nicotine patch, the gum, the inhaler, and the lozenge. And the reason that we limit the amount of NRT they can get per visit is to ensure that the client will return to get more counseling support when they need more nicotine replacement therapy. They can also receive up to a maximum of 26 weeks of NRT in a 1-year period, so that's almost 6 months worth of treatment. And then the STOP team will do follow-up surveys with all participants at 3 months, 6 months, and 12 months after enrollment. We then have our Stop on the Road workshop model. This is designed as a group psychoeducational workshop. Participants will receive a 5-week kit of NRT patches, and then the STOP program does follow-up surveys at 5 weeks, so that's the end of treatment, and then 6 months later. Okay, so after we have selected and tailored the intervention to that setting, the next step in the knowledge to action cycle is monitoring knowledge use. So how do we know that the practitioners are continuing to implement the program properly and using the evidence properly? So we have a few monitoring activities that we do. One of them is a biweekly knowledge exchange teleconference. And this is where we bring together practitioners from across Ontario, from all different practice settings that are implementing STOP. And we ask and answer questions, we provide program updates. We usually have a topic of discussion or a case study that's presented so that everyone has a chance to participate and learn from each other. We also promote continuous learning opportunities, such as these Lunch and Learn sessions. Mostly these are provided through the TEACH program, these opportunities, and we also, they also have the Community of Practice webinars. We have an ongoing coaching model, and what that means is that essentially we have a dedicated email address for every arm of the STOP program where practitioners can email in any of their more clinical questions, and we triage those questions up to the experts, which are our clinicians here at the Nicotine Dependence Clinic at CAMH. We also link with other resources as needed, so we'll link with the Pregnet's website if clinicians have pregnant clients, and you heard about Pregnets at the last Lunch and Learn. We'll link with the CanAdapt guidelines and other resources that are out there, such as the Smokers Helpline. Okay, so the next step in the cycle is to evaluate outcomes. So how do we know if any of this is working? So we have a few evaluation activities that we do. Obviously, the participant follow-up surveys that I've mentioned that provides us with the participant or the client level outcome data. So whether they've quit, we ask questions about withdrawal symptoms they've experienced, etc. We also partner with the Ontario Tobacco Research Unit, or OTRU, and they do a more organization level and system level evaluation of changes that have evolved as a result of the STOP program. We are always doing some data analysis, presenting at conferences, either presentations or posters, and we're currently writing some manuscripts for publication. So this is based on the baseline and outcome data that we have. And we also provide site feedback reports. So for every site, if they're interested in knowing how they're doing with their own clients, we'll feed that information back to the site so that they can know how they're doing. Okay, so the final step in the knowledge to action cycle is sustaining knowledge use. So this essentially gets at how do we keep the program relevant and updated, sort of that continuous quality improvement piece to make sure that it continues to be implemented. And so we're going to go through an example of a continuous quality initiative, improvement initiative that we have launched in the past year. And it is called the STOP portal. And so what this is, this slide shows an example of the STOP portal. It's an online website. It's a data collection and management tool that we launched back in January. And basically every single practitioner of the STOP program gets a password protected login to their own site where they have access to see basically everything they need to in order to run the STOP program. And the reason that we decided to move forward with this is because we got feedback from some practitioners that there was a lot of paperwork, that it was hard to keep track of some of their inventory. And so the STOP portal just really brings this all together into an easy online system. So I'm just going to point out a few things on the portal. So you can see on the left-hand side here, it tracks their current inventory levels so that sites will always know how much they have on hand and they'll be able to place an order for more products if they need it. They're able to enroll a new patient or client. What that will do is take them straight to the questionnaires that they need to fill out so that they don't actually need to use those paper forms at all if they go straight to the online system. They can search for any of their patients that is coming in so that they can, go right to doing another visit with them, etc. So this is an example of what the patient profile looks like on the portal. So every patient or client who enrolls into the STOP program gets a profile created for them. And so from the profile, they can see things like total number of weeks of NRT dispensed. So that's an easy way to keep track of how much your clients have gotten through the program. All their contact details are listed. You can see their follow-up surveys are automatically generated so that essentially when the follow-up is due, it becomes unlocked. And that way the practitioner can actually do that survey with the client if they see them. So our staff also do those surveys, but this will hopefully increase our follow-up rates. And then finally, they can use this area to open a new visit form, which is where they track the NRT that's dispensed and get that snapshot of their current smoking status. So it's all integrated into this online portal, which has been a great tool and which has been adopted by all of our sites very successfully. Okay, so that sort of sums up very briefly the knowledge to action cycle. And I think just something to point out is that it is a continuous cycle. So it doesn't end here. So we're constantly getting new information and new evidence that comes into the cycle through that knowledge funnel. And that helps inform the continuous evolution of the program. Okay, so what are some of the successes that we have seen come out of all of this? So this graph shows some of the 6-month quit rates that we have achieved through the STOP program. These are percent of survey responders, so to that 6-month follow-up survey, who have quit status of yes. And what that means is that they have not had a puff of a cigarette in the past 7 days. So we use a 7-day point prevalence of abstinence measure. And you can see that this is sort of, we sort of place this on a continuum. So on the left-hand side, you'll see some of our lower intensity interventions. So the web-based enrollment, the phone mass distribution, and our stop on the road, which is the one-time workshop. But we're still seeing quit rates in those models of 20% and over. And then you'll see on the right-hand side of the graph is our more intensive program options. So this is our, our more 26 weeks of NRT, more intensive counseling models that we do with family health teams, community health centers, addiction agencies, and now the nurse practitioner-led clinics. And through those arms, we're seeing quit rates of upwards of 30% and higher. And so this is pretty incredible considering that the unassisted quit rate, so people who are quitting smoking cold turkey with no assistance, is less than 5%. And so through even these brief interventions, we've been able to see some pretty incredible quit rates. Okay, so what is next for the STOP program? So where are we going to go from here? So obviously the cycle continues, and we are going to continue to build on the existing healthcare infrastructure in Ontario by engaging with new types of healthcare settings. And so an example of this is our nurse practitioner-led clinic project, which launched earlier this year and has been very successful so far. And we are always looking to our current program implementers, so those of you watching today, hopefully, for feedback for that continuous quality improvement piece. So what can we do to continue to make the STOP program better? We're also looking at some new research questions. So there's always new things out there that we want to look at. So everyone knows that e-cigarettes are a hot topic right now and might really change the landscape of smoking cessation as we know it. So we've recently added questions on e-cigarettes to both our baseline questionnaire and our follow-up surveys. So we're hoping to this year have a better idea of who's using e-cigarettes and why. We are also looking at the link between smoking and depression using the PHQ-9 scale, which has now been incorporated into our baseline questionnaire. And this is a validated measure of mood and depression. And finally, we're considering looking at other links with smoking, such as the link between obesity and smoking. And so we're considering incorporating questions on body mass index into our questionnaires. So we're always reevaluating what we want to look at. And of course, STOP success would not be possible without the efforts of our dedicated partners across Ontario. So all of the implementers out there who are working hard to offer this program to their clients. We couldn't do it without you. And of course, to our team here at CAMH, the research coordinators and research analysts who keep things running behind the scenes. So if you're interested in getting involved, these are the programs that are the clinics that we're currently partnering with. And you can see there our email address on our website. So please do get in touch if you are from one of these types of practice settings and you're not yet engaged with us. We'd be happy to chat about the next steps. Okay, so that's all we have for today. I think there are a lot of questions popping up on the chat. So I think what we'll do is we'll go back and go through some of these questions. Okay. Oh. Just finding, okay. Yeah. Okay, so the first question from the PTCC is, can you say a few more words about the biweekly knowledge exchange teleconferences? So are these for coordinators at the local sites, and what is covered in general? So the teleconferences are open to all of our STOP implementers. We really use it as a chance to provide updates on the program, to answer some frequently asked questions, you know, to go over some, you know, questions about using the portal, etc. So a lot of the content is fairly specific to the STOP program, and that's why, you know, we open the doors to our STOP practitioners only. And as well, what is covered, as I mentioned, we try to talk about a different topic every week. So we send out a topic beforehand. An example, at the last teleconference, we talked about patients who use marijuana and tobacco concurrently. And that generated some pretty lively discussion. And the next Lunch and Learn is actually all about that, so I won't talk too much about what we discussed. But Peter Selvey at the next Lunch and Learn will talk about concurrent marijuana and tobacco use. Some other examples, what we're talking about at our teleconference today is other resources that are out there that people have linked their clients with that have helped them in their quit attempts. So whether, you know, using the smokers helpline, using the smartphone apps, I'm not going to give away all the answers because we're talking about it soon, but that kind of thing. So we try to talk about, you know, current evidence. We've talked about e-cigarettes, so it's pretty comprehensive and just a chance for people to get together on the line and share their experiences. And we found that it has been very helpful and very informative. But again, it is, at this time, it's only for STOP practitioners just because of those specific program updates that we provide. So the next question from Debbie, can you share your forms?
Absolutely.
Okay.
Why not? They're just basic questions about tobacco history, and they're all based on either the minimal data set from the Quitline Consortium or other validated sources in the literature. So yes, happy to share.
So yeah, you can send us an email at stop.study@camh.ca and we'll be happy to share our forms with you. Okay, Amanda asked, do you need a certain number of participants in the STOP program to have access to the portal? So the answer to that is no. Every single site that is running the STOP program automatically has access to the portal because that's how they run the program, essentially by filling in their questionnaires and keeping track of their NRT. So every site that's implementing STOP has to use the STOP portal. How long between the time we fax you a referral and you contact the client? So we're currently not accepting fax referrals, I don't think.
No.
Unless you're asking about our nicotine dependence clinic at CAMH. I'm I'm not sure the answer to that question.
Unless it's a hospital-based contract? I don't know. Sorry.
Okay, the next question talks about the group model. So what is the ratio of group participants to staff? What is the number of times per year to run a group program? The number of weeks suggested? How long is each session? So we don't have any kind of rules around that. We really leave it up to the staff to develop a program that will fit into what they are doing. I would say that most sites run their groups on a weekly basis or a monthly basis, and each session is probably around 1 hour. I'm sure there's some guidelines out there for what is best for groups, but I don't have that on hand.
Yeah, if you're interested, we could ask the clinic staff to send you some information. Again, just email stop.study@cambh.ca. Quit rate for clients who try unassisted without follow-up or support.
I think so. I think we answered that. The quit rate for clients who try unassisted is less than 5%. Right?
Yes, and in the mass distribution model where we gave it for free, but they only had the initial assessment and behavioral counseling, the quit rate is lower than with the counseling models with primary care, etc. So, I mean, the evidence is that counseling support plus medication is by far the best, and the quit rates in the mass distribution model were at 10 to 15% lower than what we're seeing with the primary care model.
Okay, the next question says, with all the evidence that has been gathered by STOP, was there a better success rate with starting a program in January versus June? That's a great question.
Mm-hmm. So I think there used to be, certainly when we started the mass distribution, we started in January because of this sort of dogma that everyone wants to quit smoking for their New Year's resolution. And there is, I think, generally a little blip in January, but for the most part, people are interested in accessing STOP when they're ready. And by having it always available, I think it's much more client-centered in that way. And you know, we get the people who are ready, who are motivated at that time.
Okay, the next question is, have you considered asking about housing, whether they live in a smoker or smoke-free home?
We used to ask that question.
Yes.
And I think in the interest of brevity, we took it out. We do have data. I don't know that it's ever been analyzed, but it is an interesting question whether people who are in a household with other smokers, whether they have a more difficult time quitting. Certainly anecdotally, that seems to be the case. But yes, you've given me an idea to go and look at the data, past data now.
And on our current baseline, we ask about smoking policies in their workplace. Mm-hmm. So we do have data on both housing and workplace.
Oh, ACT teams.
Talk of partnering with assertive community treatment teams.
Because, you know, yeah, it's a possibility, I guess. Again, there are issues with, especially with social workers, it's not part of their scope of practice to use medication or to dispense medication. So if ACT, I can't remember if ACT workers are mostly social workers or not, but I do remember having discussions and there being some issue, but I'll have to review that. It's stop's been going on for, oh my God, almost 10 years. So
Almost 10 years.
it's hard to remember all of the different discussions that we've had, but I can look into it again.
Okay. There are also some ACT teams that are part of an addiction agency. So if that's the case, then you can definitely contact me to see if you're eligible under the addiction agency model. Is it possible to request a report about how your organization compares to overall quit rate percentages? Yes, so this is something that we are working on right now, and it will very soon be available to download through the STOP portal. So we will let you know as soon as that is ready to go, but very soon.
Yes, you noticed that.
So Janet asks, can you provide insight into why the quit rates at CHCs are lower than other settings?
So we did look at the data, and as many of you probably know, community health centers, their mandate is to service populations that don't otherwise have access to healthcare, and so there's transient populations, immigrant populations, newcomers to the country with language barriers, and they can be quite transient. So while they may enroll in STOP, they don't often, sometimes don't stay, or there's just many other challenges with respect to other social issues, other comorbidities and mental health issues. So their quit rate is understandably a little bit lower because of that.
Okay. So we mentioned that we're engaging with a hospital project 2013-2014. Can we explain this, and is it possible to become a partner? So the hospital project was a demonstration project, and I believe only a few hospitals were selected to be involved.
Yes, so yeah, those applications had closed. You had to apply through the ministry. So I think we have 13 hospitals that we're currently partnering with. It is, as Erin said, a very small demonstration project. Hopefully it will be successful, and the ministry will fund it, and all hospitals can become involved once we're done the demonstration project.
So not at this time, but you will find out if it is expanding.
So which hospitals are involved?
It's the same.
I can't remember.
Which hospitals are involved?
So sorry, I don't have that information.
You can email us, and we can.
Yes.
We can share. Okay, we're going to put our contact info back on the screen so that if you missed it, you can write that down. Okay, next question says, at the 6-month follow-up to assess quit rates, what is your typical response rate from the total participants that you tried to contact? That is a great question.
Yeah. We're hovering around between 35% and 45%, depending on the month. And
yeah.
So yeah, less than half, unfortunately. So we do also report intent to treat, not really intent to treat, quit rates as well, where we do an ultra conservative assumption that if we couldn't get in touch with them, then they're still smoking, and we know that that's not true, but it is a very conservative estimate of what our quit rates would be. So if we do that, you basically just have cut in half the quit rates that we showed, but it is somewhere in between those values. So we presented our best case, so and the information that we have, that we know of the people that responded to the survey who's quit.
Okay, so we have time for one more question. So around NRT dosing, does a physician write an order, or do you advise the patient to follow the package instructions, and how do you document this? So NRT does not have to come from a physician order unless that is something that the organization already requires. So some organizations have a medical directive in place where all medication orders have to come through a physician order or through a medical directive. If it's not a physician, but they are a STOP program implementer, so they have received their training in smoking cessation, then they're able to advise the patient based on following the STOP guidelines. And so that's not necessarily the package instructions. The package on label dosing is very conservative and does not allow for combination therapy and things like that. So the STOP program, because we try to follow evidence-informed practice, the evidence shows that combination therapy can be more successful than monotherapy. And so we do recommend that practitioners can go off-label and prescribe, for example, the patch plus the gum or a combination of products. So the way that it's documented is on the visit form. So we keep track of how many boxes are given out, the lot numbers, and all that medication tracking. So I think if you have questions about the Teach course, you can email Teach directly. Okay. Thank you.
Okay, everyone, so unfortunately we have run out of time. If you still have questions, please do continue to type them in the chat box. Alternatively, you can email me, tanya.abate@camh.ca. My email address is on the side menu under notes, and I will forward all your questions on to the faculty from today. So please remember, a link to the online course evaluation and post-learning assessment 2 will be sent out following today's webinar, likely tomorrow. And you will have 1 week to complete the post-learning assessment in order to be eligible to receive your letter of completion. Again, if you participated as a group for today's session, please email me by end of day today with a list of the participants. Our next Lunch and Learn webinar is coming up pretty quick, Wednesday, December 10th, on the implications of cannabis on tobacco interventions, and the presenter will be Dr. Peter Selby. Application period is now open and accessible through our website, www.teachproject.ca. Thank you, everyone, for attending today.